Good morning, students. Today we will. I am Dr.Pandre. I am from Department of Pathology. Today we will see about the tumors of the testes and the prostate. Before going the tumors of the testes, we will see the first what is the histological structure of the testes. Normally, it is it consists of the seminiferous tubules, and these seminiferous tubules are lined by the two types of the cell. The one is a spermatogonia. Spermatogonia is a germ cell, and this layer is also consists of the various type of the primary spermatocyte and secondary spermatocytes, along with the spermatids and the spermatozoa. Second cell is a Sertoli cell. It is a supportive cell to the germ cell. It produces the testosterone, little amount of the estrogen. Among this, there is a fibrovascular stroma. In the fibrovascular stroma, there is a presence of the special type of the cell, that is a Leydig cell. It is a testosterone secreting cell. Then coming to the actual tumors of the testes. Tumors of the testes are classified into the germ cell tumors, sex cord stroma tumors, and the lymphoma of the testes. Germ cell tumors are classified into the seminomatous tumors and non-seminomatous tumors. Seminomatous tumors are the seminoma, classical seminoma, and spermatocytic seminoma. Non-seminomatous tumors are the embryonal cell carcinoma, yolk sac tumor, choriocarcinoma, and the teratoma. These are the main tumors in the germ cell. The second category is a sex cord stromal tumor. In the sex cord stromal tumor, this category, Leydig cell tumor and Sertoli cell tumor, these constitutes the large amount of the cases. And third category is a gonadroblastoma. Last one is a testicular lymphoma. In this testicular lymphoma, the majority is a non-Hodgkin's lymphoma is seen here. First one is a germ cell tumor. In the germ cell tumor, first we see what are the seminomatous tumors, are those classical seminoma, and the second one is spermatocytic seminoma. The age of occurrence of this disease in the younger age group or in the adult age group, that is a 15 to 35 years of the age. It is associated with the TDS, that is the testicular dysgenesis syndrome, cryptorchidism, hypospadias, and poor sperm quality. Cryptorchidism, what is a cryptorchidism? Cryptorchidism is an undescended testis. At the time, normally at the time of the birth, testes descend in the scrotum or the after it can be a descend in the scrotum up to the 1 year of the age. If it remains in the abdomen or in bunny cavity, it is called as a cryptorchidism. That is one of the factor that causes the seminoma testes. Most of the tumor originates from the intratubular germ cell neoplasia. First, we will see about the classical seminoma. In this is a common type of the tumor. It is never occur in the infancy, and the peak age is in the adult age group, 15 to 45 years, peak in the 30s. It is identical or the synonymous to that of the dysgerminoma in the female. On the gross examination of the seminoma, it is a bulky mass. It rises to the size of the 5 to 10 times of the testes. On the cut section, the characteristic appearance is lobulated, and it is a devoid, means there is no areas of the hemorrhage and the necrosis. It is devoid of the hemorrhage and the necrosis. The tunica albuginea is not penetrated. This is a spermatic cord, and this is a tumor, that is a seminoma. On the cut section it shows the presence of the lobulated appearance, and it is characteristically there is a devoid of the absence of the hemorrhage and necrosis that will be seen in the other non-seminomatous germ cell tumors. Microscopically, it shows the presence of the sheets of the cell, and these sheets of the cells or the nest of the cells are separated by the thin fibrous septa. That is, the fibrous septa is infiltrated by the T lymphocyte. Fibrous septa is infiltrated by the lymphocyte, mainly the T lymphocyte. The seminoma cells means the cells which are arranged in the sheets. They are individual cell are the large cell with round polyhedral distinct cell membrane and watery cytoplasm, and it has a large 1 or 2 central prominent nucleoli that is characteristically present in the seminoma. The mitosis vary in the frequency. This is a microscopic picture of the seminoma testis, classical seminoma. These are the sheets of the cells. They are arranged in the sheets and they are separated by the thin nest of the sheets of the cells are separated by the thin fibrous septa, and this fibrous septa is infiltrated by the lymphocyte, mainly the T lymphocyte. This is the higher power view of the same, shows the round polyhedral cell with the watery cytoplasm, distinct cell membrane, and 1 or 2 prominent nucleoli are present. And this is a thin fibrous septa which shows the presence of the infiltration by the T lymphocyte. Second one is a spermatocytic seminoma. Spermatocytic seminoma, the incidence of this disease is 1 to 2% of the germ cell. It is seen in the older age group and mainly above the 65 years of the age. This tumor is slowly growing and it rarely metastasizes, so it has an excellent prognosis. On the gross examination, this tumor is larger than the classical seminoma. There are 3 types of the population are seen in this in the microscopy: medium size cell, smaller cell, and the scattered uninucleate or the multinucleate type of the giant cell. In the medium size of the cell, which are most numerous, contain the round nucleus and the eosinophilic cytoplasm. Smaller cells looks like resembling the spermatocyte. And there is also presence of the giant cell. It may be uninucleate or the multinucleate. 15% of the seminoma contains a syncytial trophoblast. There is a elevated HCG levels will be seen if in the blood. There will be a serum HCG level will be increased. In the IHC, it expresses the c-kit and the blood. IHC means this is a special technique, that is a immunohistochemistry. The basic principle of this is a antigen-antibody reaction, and this antigen-antibody reaction will be identified by adding the chromogen, and this chromogen will give the color to the reaction if there is a antigen-antibody reaction. That means the antigen is present in the tumor tissue and antibody against to that is added, and the chromogen is added to identify the reaction. In this is special technique, advanced technique, that is it expresses c-kit and the PLAP. These are the antigen which are present in the tumor tissue. PLAP is a placental leukocyte alkaline phosphatase. Then this is a teratoma. Teratoma is a non-seminomatous germ cell tumor. We have seen the seminoma in the seminoma, classical seminoma and spermatocytic seminoma. And the second category is non-seminomatous germ cell tumor, the teratoma. Teratoma arises from the totipotent cell. and there is a heterogeneous population of the cell will be present. That means it may be arises from the one or more than one germ cell tumor. It may occur at any age of the they may occur at any age from infancy to the adulthood. In the infancy, these tumors are the pure tumors, and in the children and in the infancy, they are the pure tumors, and in the adults, pure teratoma are very rare, constituting only 2 to 3% of the germ cell tumor, because these tumors are usually mixed with the other germ non-seminomatous and the seminomatous germ cell tumors. Teratoma on the gross examination, size of the tumor is 5 to 10 centimeter, and because they are composed of the various tissue on the gross examination, it has a heterogeneous appearance. At some places it may show solid areas and presence of the cartilage and also the cystic areas. The hemorrhage and necrosis indicates the admixture of this tumor with the other tumor like imperial cell carcinoma or the choriocarcinoma. These are the other non-germ cell, non-seminomatous germ cell tumors. This is a gross examination of the teratoma. It is a heterogeneous appearance. Some areas are solid areas and some cystic areas are seen here. There is also a presence of the on the cross section. There is a presence of the cartilage over here. There are 3 types of the teratomas. Will be seen in the mature teratoma and the immature teratoma and a teratoma with malignant transformation. Mature teratoma shows the presence of the various heterogeneous structures like various structures such as the cartilage, smooth muscles, mucosal epithelium, squamous epithelium, transitional epithelium, or any other mesenchymal epithelium can be seen. Immature teratoma is incompletely differentiated, but the primitive or embryonic structure is more large amount of the primitive structure is present. Presence of the mainly the neural structure in the tissue is identification for the immature teratoma. Teratoma with a malignant transformation. It is a rare form in the teratoma. In the any one component may transform into the malignancy. It is called as a teratoma. Suppose there is a squamous component that converted to the malignancy and shows the presence of the squamous cell carcinoma, we call it as a teratoma with a malignant transformation. This is a microscopic structure showing the presence of the various tissue like a cartilage over here, adenoid tissue, that is a glandular tissue, fat tissue, mesenchymal tissue. This is the classical picture of this teratoma. Most of the tumors in the testes are the germ cell tumors are usually mixed tumors. Near about 60% of the tumors are the mixed tumors, and mainly most of the tumors are mixed. Teratoma is mixed with the imperial cell carcinoma and the yolk sac tumor and also the choriocarcinoma. Then coming to the spread of the tumor. The spread of the tumor occurs by the lymphatic route and by the hematogenous route. These are mainly the lymphatic route, or it may occur through the hematogenous route. Third one is second one is embryonal cell carcinoma. Embryonal cell carcinoma, age of occurrence of it occurs in the adult age group, that is 20 to 30 years of the age. Tumor is more aggressive than seminoma. On the gross examination, it is smaller than the seminoma. Most of the time, only a small part of the testis is involved in this tumor. On the cross section, it shows the presence of the area of the hemorrhage and the necrosis. It is very difficult to demarcate from the surrounding area of the normal testes. Extension through the tunica albuginea to epidermis or cord frequently occurs. This is the gross appearance of the embryonal cell carcinoma. This is the testes and showing the presence of the tumor here. It is very difficult to demarcate the tumor from the normal testes, and there is the presence of the areas, and the area of hemorrhage and the necrosis is characteristically seen in the embryonal cell carcinoma. Embryonal carcinoma, in the microscopy of this, there will be a presence of the various types of the patterns, that is alveolar or the tubular patterns may be seen. There may be a presence of the papillary convolutions. Cells may be arranged in the sheets. Cells may be arranged in the sheets, and it shows the neoplastic cell have a epithelial anaplastic appearance. They are large and anaplastic cell with a hyperchromatic and the prominent nucleoli. IHC means immunohistochemistry. I have explained who. In this, it is a positive for OCT and the BLAB, and negative for the CKIT. These are the markers which are used for the identification of the tumor. This is a microscopy of the embryonal cell carcinoma. In this, the cells are arranged in the alveolar pattern here, and tubular pattern, and some are arranged in the sheets. They have a epithelial appearance, and the cell are anaplastic. Anaplastic means lack of differentiation. Lack of differentiation is seen here. Then the prognosis of this disease is then the yolk sac tumor. It is also called as endodermal sinus tumor. Endodermal sinus tumor is most common testicular tumor in the infant up to the age of the 3 years of the age. The prognosis of this tumor is good, in contrast to the embryonal cell carcinoma, which has a bad prognosis. The prognosis of this tumor is good. On the gross examination, tumor is non-capsulated. On cut section shows the presence of the yellowish white areas, mucinous in appearance. Microscopically, it shows the presence of the typical appearance, that it's lace-like structure with medium-sized cells with the flattened epithelium, and that there is a typical arrangement is a seen, that is arrangement like a Schiller, we call it as a Schiller oval bodies. In this, there is a cells are arranged around the capillaries. Cells are arranged around the capillaries, and these cells are the anaplastic, highly neoplastic cells. This is a Schiller. 50% of the cases show the presence of the Schiller oval bodies. They are the neoplastic cells are arranged around the capillaries. In the IHC, immunohistochemistry, it produces the alpha-fetoprotein, and it expresses the alpha-fetoprotein alpha-1 antitrypsin. As is immunohistochemistry, it is a special technique. Then, last one is choriocarcinoma. It is a highly malignant testicular tumor. Originates from the syncytiocytoplast and cytotrophoplast. Pure choriocarcinoma is very rare. It is always associated with the other embryonal cell carcinoma or the yolk sac tumor. On the gross examination, they cause no testicular enlargement. Characteristically, there is no testicular enlargement, and are detected only as a small palpable nodule. Very small nodule will be present, and this nodule will be present, shows the presence of the hemorrhage and necrosis. It is a characteristic feature of this tumor. It is extremely common. In the microscopy of this, it shows the presence of the two types of the cell, that is a syncytial malignant syncytial trophoblast and cytotrophoblast. In the syncytial trophoblast are the large, have a many irregular lobular hyperchromatic nuclei, and with the it shows the presence of the anaplasia. And the cytotrophoblast are the more irregular and tends to be polygonal with a distinct border and clear cytoplasm. Both these type of the cells, syncytial trophoblast and cytotrophoblast, have a anaplastic features of the malignancy. And here is showing the proliferation of the syncytial trophoblast and cytotrophoblast. This is anaplastic tumor. Anaplasia is present here. Hyperchromatism. There is alteration in the ancirrhosis, abnormal mitotic figures within scanty cytoplasm, pleomorphism in the cells. Individual cells will be also present. That is the, and with the features of the anaplasia present. Then the second category is a Leydig cell, sex cord stromal tumor. In the sex cord stromal tumor, there are Leydig cell tumor and the Sertoli cell tumor. Leydig cell tumor and the Sertoli cell tumor. These are sex cord tumors. They elaborate the antigen. They are hormone producing tumor. They are also called as a hormone producing tumor. They elaborate androgen and the estrogen. Most of the cases occur in the 20 to 60 years of the age. There is a wide range for the occurrence of the disease. Common presenting feature is a testicular swelling. Testicular swelling is present. There is enlargement of the testes. There is a presence of the gynecomastia. That means there is enlargement of the breast in the male. And third, and in the children there is a sexual precocity. In the Leydig cell tumor, on the gross examination, it is a well circumscribed tumor. It is usually a less than 5 centimeter in the diameter. On the cut section, it shows a characteristic yellowish brown appearance, or the yellowish golden brown appearance, or the golden brown surface will be observed. In the microscopy, there will be a Leydig cell hypoplasia will be seen, that there will be a proliferation of the Leydig cell, and these are the large round polyhedral cell and distinct rounded central nucleus and abundant eosinophilic cytoplasm. And the cytoplasm contains the lipid granules or the lipid granules. This tumor usually that remains benign in nature, but the 10% of the cases may become aggressive and shows the metastasis. Then the second part, first we have seen all the germ cell tumors, seminomatous, non-seminomatous, germ cell tumor, sex cord stromal tumor, and the lymphoma of the testes. Now the second part of this is lesions of the prostate, mainly the BPH, and we will see the BPH and the adenocarcinoma, benign prostatic hyperplasia, and the adenocarcinoma of the testes. Before going to the histopathology or the pathology of this, we will see what is the normal weight of the gland. It is a 40 milligram in the weight. It is composed of the 5 lobes, but in the adults there are 3 lobes, 2 lateral and 1 medial lobe will be present on the anatomy. This is the anatomy. On the histology, there is a glandular proliferation. It is composed of tubular alveoli embedded in the fibromuscular tissue. This, and along with there is these glands are lined by the 2 types of the epithelium, lower cuboidal and the inner columnar. That is the character, and they will be thrown into the food. And along with this, there is a separated. These glands are separated by the thick fibrovascular septum. Coming to the BPH, that is a benign prostatic hyperplasia. Benign prostatic hyperplasia, it is the most common, extremely common disorder in the male, and it is seen after the 40 years of the age. 90% of the cases are present with above the 90 years of the age, and only the 50% of the cases will show the presence of the clinical signs and symptoms, the mainly present with the urgency of the micturition. In the etiology, there is a main component that is there is an increase in the epithelial and the stromal component. Both the components are increased, and there will be a decrease in the cell death will be seen, and there is a proliferation of the stroma, and the muscle proliferation, fibromuscular proliferation will be present. On the cross examination, the characteristic finding in this BPH is there is a nodular arrangement, nodular enlargement of the prostate it indicates that it is a benign lesion. Characteristically, it shows the presence of the nodularity. On the cut section, there is a homogeneous white inconsistency, and there may white in the consistency. This is a gross picture of the prostatic hyperplasia or the benign prostatic hyperplasia. There is a presence of the nodularity over here. There are many small lobules are seen here. Nodularity is a feature of the benign prostatic hyperplasia. Microscopically, it looks seen. In this, there is a nodularity is present here also. Microscopically, the hallmark of the BPH is a nodularity. That's a characteristic feature. There will be a proliferation of the fibrous and the muscular stroma. And this stroma, in this, the various types of the glands, they are thrown into the papillary fold, and there will be a intact basement membrane. These papillary gland or the adrenal gland, prostate, are lined by the two types of the epithelium. That means those are the basal tubule and the inner columnar. There may be a changes can be seen. Why that there will be a change? If the lesion stands for the longer time in the body, there are changes can be seen like a squamous metaplasia. Metaplasia means one type of the normal epithelium will be a change by the another type of the normal epithelium. There may be a presence of the areas of the infraction can be present. This is a microscopy of the prostatic hyperplasia. In these glands are infolding. There is infolding of the gland and shows the presence of the two types of the epithelium, basal tubule and the inner columnar. Along with this, there is a proliferation of the fibromuscular stroma, and the nodularity is on the microscopy also. When it is seen under a scanner, that will be observed as there is a presence of the nodularity. It is a benign. Nodularity is a characteristic feature of the benign lesion. Then the prostatic adenocarcinoma. Prostatic adenocarcinoma. In this, most of the cancer in the mean accounting for the 29% of the cancer in the US. There is a decrease in the cancer rate in the last 20 years. The incidence of the disease is it occurs about 50 years of the age, and in the etiology, androgen play an important role, and this is seen in the Asian and frequently occur in the blacks. In the etiology, androgen play an important role. There is some chromosomal abnormality is also present, that is mutation in the gene. In the most of the carcinomas, the prostate, they arises from the peripheral zone of the glands, and so usually they occur in the peripheral zone. Usually the patient come to the OPD in the late stage of the disease. On the gross examination, the neoplastic tissue is gritty form and difficult to visualize the tumor. There is a homogeneous proliferation of the cells will be seen. There will be a devoid of the nodularity is seen in this, which is seen in the BPH, and there is no nodularity in the adenocarcinoma. There may be involvement of the seminal vesicle or the base of the bladder is seen. There is a homogeneous proliferation of the tumor cells. On the cut section, there is a gritty sensation. In the microscopy, the microscopically the glands are usually of the smaller size, smaller than the benign glands, and they are lined by the only a single layer of the epithelium. Double layer epithelium is replaced by the single layer epithelium by the low columnar or the cuboidal layer of the epithelium, and in this outer basal layer are absent. There is a branching and papillary enfolding is absent like a BPH. Cytoplasm is amphiphilic. There is a nuclear variation in the size. That means there is a presence of the pleomorphism is also noted on the microscopy. Mitosis is more common. It is a very aggressive tumor. This is a microscopic picture showing these are the neoplastic glands, malignant gland, having the single layer of the epithelium with all the features of the neoplasia, that is a hyperchromatic nucleus with the altered tensor ratio, abnormal mitotic figures, and these are the normal. This is a normal tissue. This is a malignant tissue, and this is that is side by side. There is a presence of the normal tissue. There is a double layer epithelium is present here. Here is a single layer epithelium is present. Double layer epithelium lost. Here is also the glandular malignant glands are observed here. This is also another picture showing the presence of the adenocarcinoma prostate, and there is a infiltration of the fibromuscular stroma is seen. These glands are itself present in the fibromuscular stroma. In the grading of the Gleason score is done for the grading of the carcinoma prostate. It is done, Gleason scoring is done by the glandular differentiation and the stromal infiltration by the tumor cells. Metastasis usually seen in the para-aortic group of the lymph node. Hematogenous metastasis is seen in the bone. Hematogenous metastasis is commonly seen in the vertebral column. This carcinoma prostate first metastasized to the vertebral column. There may be a massive visceral dissemination may be seen. Characteristically, there is a vertebral column metastasis is most commonly present. These are the Gleason's grade, and these Gleason's grade is done grade 2, and these are the grading low grade, moderately differentiated, and poorly differentiated. In the poorly differentiated, the cells are arranged in the glandular pattern is lost. Here, the cells are arranged in the sheets. Cells are arranged in the sheets, and here there is the glands are the small and it is a nearly. They are arranged back to back. Here also the glands are arranged back to back, and it is replaced by the double layer epithelium by the single layer epithelium. So it is a low grade, moderately differentiated, and poorly differentiated means identification of the gland is not possible here. The cells are arranged in the sheets with all the features of the malignancy. This is a vertebral spine metastasis. It is commonly this prostate carcinoma metastasized to the vertebral column. These white areas are the metastasis with the prostatic carcinoma. Then coming to the prostate histopathology, that is normally the penis is covered by the skin or the foreskin, and it is covered by the stratified squamous epithelium. The benign tumors which are seen in the penis are the condylum acuminatum. In the pre-malignant conditions are the Bowen's disease and erythroplasia period. Then the squamous cell carcinoma of the penis is important for your point of view. The incidence of this disease is between the 45 to 60 years of the age, most commonly seen in the black people. It is uncommon in the Jews and Muslim because of there is a practice of the ritual practice of the circumcision. What is the etiological factor? Etiological agent is HPV 16 and 18. HPV means a human papilloma virus. Number 16 and 18, they are high risk viruses, will cause the squamous cell carcinoma penis in the male. There are two types of the patterns will be observed on the cross examination: papillary growth and the flat growth. Papillary growth may be a cauliflower type of the growth, and flat growth is usually a ulcerated papules are seen. This is on the microscopic examination. It shows the presence of the two types of the malignant squamous cell carcinoma. It can be a well differentiated or it can be a moderately differentiated. Well differentiated means there is a presence. There is an infiltration of the squamous epithelium into underlying stroma, and presence of the keratin pearl will be differentiated from the well differentiated, and again the depth of the tumor will differentiate the moderately differentiated carcinoma. In this mention in the tumors of the testes, you must know the tumors, what is the classification of the tumor of the testes, how it is classified, mainly the germ cell tumor. On the details about the germ cell tumor you should know, and the classification is asked in the examination for the short answer question. And also the other sex tumor and the adenocarcinoma you must know for the MCQs. Thank you. कधी पण लवकर